Welcome to this explainer. If you or someone you care about has recently gone through a total knee arthroplasty, a knee replacement, you probably already know that just making it out of the operating room is a massive victory. But truthfully, the actual surgery is really only half the battle.
So, the big question kind of hanging in the air is, the surgery is done, now what? It's a huge question to grapple with, right? Because the real work, the actual chronological journey of your recovery, starts the exact moment you leave that operating room. It takes a ton of dedication for sure, but the good news is that it's a highly structured, totally predictable process.
Okay, let's dive right into this. We're going to break down this journey into 5 clear steps. 1. Winning the battle against pain. 2. Phase 1, which is acute hospital care. 3. Phase 2, your home-based therapy. 4. Phase 3, outpatient rehabilitation. And finally, 5. Returning to active life.
Starting with Step 1, winning the battle against pain, and setting the foundation for rehab.
Well, before you can even think about starting physical therapy or even attempt to walk down a hallway, you absolutely need a solid shield against postoperative pain. Think about it. If your pain isn't controlled, your rehabilitation is severely impaired, and that inevitably means a prolonged, really uncomfortable hospital stay. So modern medicine builds this shield using something called multimodal analgesia. To define it simply, it's combining different techniques and medications to target pain through various mechanisms. Think of it like your essential armor. By blocking pain signals from multiple different angles all at once, doctors can significantly reduce your overall need for heavy narcotics. It's just a much smarter layered defense.
Now, what's really interesting is how these 4 specific methods work together in practice. You have neuroaxial strategies like spinal and epidural anesthesia for rapid, continuous relief. Then there are peripheral blocks, specifically the femoral nerve block. This provides major targeted pain relief directly to the knee. But there's a trade-off here. It causes temporary leg weakness that you will literally have to manage when you start your early therapy. We also layer in non-opioids, things like NSAIDs and gabapentin, to reduce inflammation and anxiety. And doing all of that limits the need for the final category, opioids, which are usually handled via patient-controlled IVs or oral meds.
Once that pain management foundation is locked in, we transition right into the physical rehab timeline. Over the next year, you're going to conquer 3 specific phases. Phase I in acute care for the first few days, Phase 2 at home for a few weeks, and Phase 3 outpatient care, which spans the bulk of your first year.
All right, Phase 1, acute hospital care, covering days 1 to 3. You might be thinking you get to just rest in bed after surgery, but actually, physical therapy starts incredibly early. It's an amazing shift in medicine. Decades ago, patients were often kept bedridden for weeks after a joint replacement. Not anymore. Today, you are up immediately, encouraged to begin weight-bearing as tolerated on postoperative day 1. On that very first day, you'll tackle your initial core exercises, ankle pumps, quadricep sets, gluteal sets, and heel slides. It's fascinating how much cause and effect plays a role here. For example, those simple ankle pumps, they aren't just for mild flexibility, they are directly responsible for preventing dangerous blood clots by keeping the circulation moving in your lower leg.
So here is the crucial point. You have a very specific target to hit before you can leave the hospital, and that magic number is 80 to 90. That means achieving 80 to 90 degrees of knee flexion. Along with getting that bend, you need to be able to walk 75 to 100 feet and safely navigate stairs. These are the concrete, non-negotiable criteria required by your care team to finally discharge you to the comfort of your own home.
Next up is Phase 2, home-based therapy. This covers weeks 2 through 4. Now that you're back in your home environment, the clinical goals shift significantly. It's no longer just about basic safety and avoiding clots, right? The focus is now entirely on increasing your independence and preparing for real community reintegration. We're talking about getting you back to normal. You'll be doing a lot of functional strengthening in very practical steps: sit-to-stands, mini squats, and step-ups. To translate the medical jargon for a second, what these functional steps are actually doing is actively recruiting the essential stabilizing muscles around your new knee. We're talking specifically about muscles like the vastus medialis obliquus. That's the inner quad muscle that keeps your kneecap tracking perfectly straight. And doing those functional exercises leads to a highly visible, incredibly exciting sign of progress during Phase 2, gaining balance. As your stabilizing muscles get stronger and your balance improves, you actually get to graduate from that bulky walker to lighter assistive devices like crutches or a cane. It's a huge psychological and physical milestone.
Which brings us to Phase 3, outpatient rehabilitation, covering months 1 through 12.
This is the final and longest phase, where your ultimate goal is fully normalizing your gait, so completely getting rid of any lingering limp, and regaining full strength and endurance. Now, a successful trajectory means achieving 0 to 110 degrees of range of motion, which you absolutely need for functional activities like going downstairs smoothly. However, a delayed trajectory is a serious red flag. If you have less than 70 degrees of flexion by week 4, you risk falling behind. If the joint gets too stiff, doctors might need to intervene with something called manipulation under anesthesia. That's where they forcefully break up the scar tissue while you're asleep. Definitely something we want to avoid.
So to avoid that stiffness and keep you progressing smoothly, Phase 3 incorporates rebuilding endurance and proprioception. You'll engage in fantastic low-impact aerobic activities like stationary cycling, swimming, and distance walking. But a brilliantly used tool here is the rocker board. A rocker board forces your nervous system to continually adjust to instability. It helps you regain your proprioception, which is basically your body's innate sense of balance and equilibrium in space.
Finally, Section 5. Returning to active life. Getting back to your normal, everyday life is the ultimate payoff of this entire journey. But we do have to establish some clear boundaries for what your new mechanical knee can safely handle over the coming decades. Allowed low-impact sports include walking, doubles tennis, and using an elliptical trainer. These are fantastic. What you absolutely must avoid are high-impact sports like running or heavy repetitive lifting. You really have to separate the safe, non-contact activities from the high-impact ones. Why? Because the harsh, repetitive pounding of running can actually lead to premature implant failure, and nobody wants to go through this whole process twice.
Which brings us to our final thought for this explainer. How does an active, modified lifestyle protect your implant long-term? It's something I want you to really reflect on. The goal was never just to heal from surgery. It's to thrive for decades. By making smart, modified activity choices, staying incredibly strong but avoiding high-impact stress, you aren't just completing your recovery. You are ensuring that your brand new knee lasts a lifetime. Thanks so much for joining me on this explainer, and keep moving forward.